Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is right and left atrial enlargement. The most important concepts that one should remember in case of cardiac chamber enlargement or hypertrophy are abnormalities will seen in waves representing depolarization of the chamber, that is P wave for atria and QRS complex for ventricles. And there will be deviation of axis of particular wave toward right or left depending on site of hypertrophy. So in case of atrial enlargement, changes will be seen in P wave with deviation of P wave axis. I would highly recommend to watch basics of ECG first to understand this video better. Let's see how P wave is formed. P wave is best studied in lead V1 and lead 2. As discussed in previous video, right atrial depolarization starts before left atrial depolarization. Vector for right atrial depolarization is directed toward V1 electrode. Hence, lead V1 shows positive deflection. Left atrial depolarization starts after a slight delay and its vector is directed away from V1 electrode. Hence, lead V1 shows negative deflection. Hence, P wave in lead V1 is biphasic with initial positive deflection and terminal small negative deflection. Vector formed by both atrial depolarization is directed toward positive pole of lead 2. This lead shows positive P wave. Initial part of wave is formed by right atrial depolarization and terminal part is formed by left atrial depolarization. Combination of these two waves forms P wave in lead 2. Normal duration of P wave in lead 2 is 80 to 110 milliseconds and its amplitude is up to 0.25 millivolt, that is 2.5 small boxes. Left atrial activation vector becomes stronger in left atrial abnormality. As a stronger vector is going away from V1 electrode, terminal negative deflection of P wave in lead V1 will increase in amplitude and duration. Duration of terminal negative deflection is more than 30 milliseconds and amplitude is more than 0.1 millivolt, that is 1 small box. P wave vector becomes stronger and shifts to left. As a result, terminal part of P wave in limb lead increases in duration and amplitude. This appearance of P wave looks like back or hump of a camel. Hence it is called as camel hump appearance. This pattern is also called as P mitral, as it is usually present in cases of mitral wall abnormalities. Duration of notch or hump is more than 40 milliseconds. If leftward shift is significant and let's say up to 0 degrees in frontal plane, in such cases most prominent P wave will be seen in lead 1 instead of lead 2. So ECG features of left atrial enlargement in lead 2 are bifid and wide P wave with duration more than 110 milliseconds and distance between two peaks, that is duration of hump more than 40 milliseconds. In lead V1, terminal negative deflection more than 30 milliseconds in duration and more than 0.1 millivolt in amplitude. In right atrial abnormality, right atrial activation vector becomes stronger. As vector coming toward V1 electrode becomes stronger, initial positive deflection, which represent right atrial activation, increases in duration and amplitude. Its duration is more than 40 milliseconds and amplitude is more than 0.15 millivolt, that is 1.5 small boxes. P wave vector also becomes stronger and deviates toward right. Because of this, initial part of P wave in limb leads increases in duration and amplitude, and tip of this wave is peculiarly pointed instead of normal blunt tip. As increased duration of initial component still overlap with terminal part of left atrial activation, total duration of P wave remains normal. Amplitude is greater than 0.25 millivolt, that is 2.5 small boxes. If rightward shift of P wave axis is significant, let's say up to 90 degrees, in such cases, instead of lead 2, most prominent P wave will be seen in lead AVF. ECG features of right atrial abnormality are Increase amplitude of initial positive deflection of P wave in lead V1. Tall pointed P wave in limb leads. P wave axis deviation to right. When all these three changes are present, it is called as P pulmonale. When P wave axis is deviated to 90 degrees, tallest P wave is seen in lead AVF. In cases of COPD, right atrial abnormality sometimes manifests as prominent negative deflection in P wave in lead V1 and lead V2. But wait, prominent negative deflection? We just learned that prominent negative deflection of P wave in lead V1 is a feature of left atrial abnormality. Then how come prominent negative deflection represent a right atrial abnormality? In cases of COPD, there is hyperinflation of lungs, which makes dome of diaphragm flat, and heart is shifted downward. As discussed in basics of ECG, negative pole of precordial lead is at center of heart. That's why this shift of heart also changes orientation of lead axis of both lead V1 and V2. Moreover, P wave axis is often deviated toward 90 degrees, which makes P wave axis going away from V1 and V2 electrode. Hence, there is prominent negative deflection in lead V1 and V2. In this ECG, lead V1 and V2 have prominent negative deflection in P wave. Question is how to know whether this pattern is due to left or right atrial abnormality. If you look closely, lead V5 shows prominent S wave, which is a sign of right ventricular hypertrophy. Moreover, P waves are tall and pointed in limb leads, and it is tallest in lead AVF, indicating right axis deviation of P wave axis. Both these features are seen in COPD patients. Hence, this prominent negative deflection of P wave is due to right atrial abnormality. This confusion can also be cleared by shape of P wave. In right atrial abnormality, slope of interscoid deflection of P wave is sharp, while in left atrial abnormality, slope of interscoid deflection of P wave is normal. In last ECG, P wave in lead V2 show sharp slope of interscoid deflection. Hence, this P wave represent right atrial abnormality. QRS changes are present in right atrial abnormality associated with tricuspid valve insufficiency. These changes are combined effect of presence of right ventricular hypertrophy and anatomical shift of heart caused by dilated right atrium. These changes are lead V1 showing QR pattern, diminished QRS amplitude in lead V1, and markedly increased QRS amplitude in lead V2. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.